Hello, future doctors. How are you all? Welcome back to MedStep's Internal Medicine Series, episode 8 by Dr. Anand. So today we are going to discuss very important topic, that thing we call neuropathy. So this is the most important topic we can see in OPD department, in geriatrics, in many different types of patients. So we call peripheral neuropathy. So this is a high yield topic for MBBS students, or if you are doing internship, or if you're preparing for FMGE, NEET PG, or USMLE and other medical entrance exams. This is very important and high yield topic. By the end of this section, you will understand what is neuropathy and causes, pathophysiology, clinical features and diagnosis, investigation and management, and important exam points for OSCE settings, and for OPD, how to take history, physical examination, everything we are going to cover in this video. Okay, so without time waste, let's get started. So what is neuropathy? If you're seeing anything related to neuro, means it's related to nerves. Okay, so first of all, we have peripheral neuropathy, means understanding nerve damage. So peripheral neuropathy is a disorder caused by damage or dysfunction of peripheral nerves. So the peripheral nerves is a disorder caused by damage or dysfunction of peripheral nerves. You can see here, these are the peripheral nerves. Okay, so whenever that nerve become damaged, then what will happen? It will convert into pathy. Pathy means not dysfunction, impaired function of the nerve. Okay, so this is the nerve. You can see nerve blood supply. Here what will happen? This is the, we call the nerve fiber. Here we have the nerve fiber covered with this is for example, this is axon covered with myelin sheath. If any problem with this myelin sheath, any problem with this myelin sheath, then we call that is damaged nerve. So here what will happen? These are the damaged nerves we can see. Then it will cause dysfunction of the that nerve function. Okay, so the peripheral nerves include sensory nerves, the sensory nerves, and motor nerves, and autonomic nerves. So if you're seeing here, this is the nerve. You can see this is healthy nerve, it will look like this. This is unhealthy nerve, it will look like this. Okay, so in, if you're seeing here, we have total 3 different types of nerves. You can see here, that is first one sensory nerve, first one motor nerve. I'm highlighting here. The motor nerve is main thing is to help do muscle movement. So it will control the voluntary muscle movements like walking, grasping, and things, or talking. So these are the things we can see in motor nerves. Okay, next we can see that is sensory nerves. Sensory nerves main function will be like, you can see pain, temperature, and touch. And here the sensory nerves is transmit information like the feeling of a light touch and temperature or pain from a cut. So normally in skin we have some receptors. For example, um, we call mechanoreceptors or nociceptors. Okay, so these are the receptors we have for our in skin. Okay, then from that skin it will, it then from that skin the nerve will get innervation, the sensory things, we can see synaptic cleft and synapses. Then the patient will get the sensation. So the sensory nerves is the main function is pain and temperature and touch. Next we can see that is autonomic nerves. The main autonomic nervous function will be, you can see like autonomic, like blood pressure, sweating, bowel, and bladder control. Okay, so it will automatically, it will operate heart rate, blood pressure, digestion, and sweating. Okay, so this is peripheral neuropathy. A neuropathy means simply nerve damage. So it's a clinical disorder resulting from structural or functional impairment of peripheral nerves, causing sensory, motor, and or autonomic symptoms. Okay, so if you're seeing here, this is the division of peripheral nervous system. Actually, our nervous system made by 2 things. One is brain and spinal cord. Okay, so here what will happen in this brain and spinal cord. In we call that is from spinal cord, what are the nerves we are getting and everything. Brain and spinal cord, that is central nervous system. Then after we can say another nervous system, that is peripheral nervous system. So this is we called central nervous system. Brain and spinal cord includes. From except this brain and spinal cord, some nerves will come outside the thing we call peripheral nervous system. So this peripheral nervous system divided into two different types. One is um, somatic and another one is autonomic. So in this somatic nervous system, you can see it communicates with sensory organs and voluntary muscles. And in sensory, we can see efferent nervous system, sensory input. Next one, motor, that is efferent nervous system, and it's like motor output. Next, we can see autonomic nervous system. In autonomic nervous system, it communicates with internal organs and glands. You can see two different types of nervous system. One is sympathetic and parasympathetic. In sympathetic division, we can see arousing means flight or fight. In parasympathetic will be like calming means rest. Okay, so this is the things we can see. Next one, somatic nervous system. That is the main thing right now in peripheral nervous system we have to learn, because in nervous system, the sensory nervous system mainly we saw pain, touch, and temperature. In motor efferent nervous system, we saw muscle strength, right? So, if you're seeing pathophysiology, we have to first of all we have to understand the mechanism of nerve injury. First of all, whenever in neuropathy, we can see first of all some underlying diseases. What it means? Underlying diseases means it maybe you can see diabetes, okay, or kidney problems, or in autoimmune problems. So these are the things many, and age, geriatrics, okay, and hypothyroidism. These are the main underlying disease we can see. Then after it will cause or radiculopathy, or disc bulge, or herniation, okay, or spondylosis. So these are the things can cause that nerve related problems. So that's why our Cauda-Equine syndrome. So these are the things. So underlying disease, it will cause metabolic, toxic, or immune injury. Then after we have some axons, the axons will get damaged and myelin will get damaged. So whenever the axon and myelin will get damaged, the nerve conduction of velocity will reduce. Okay. Then after we can see impaired signals transmission. Impaired signal transmission means how much current that part have to get is not going to get. So that's why we call that is impaired signal transmission. Then after, because of the thing can be sensory, motor, and autonomic, sometimes we can see in pathophysiology. Okay. Next, we can see here types of nerve damage. We have total 3 different types of nerve damage. One is axonal neuropathy, demyelinating neuropathy, and mixed type. In axonal neuropathy, we can see axonal degeneration. Next, we can see demyelinating neuropathy. We can see myelin destruction. Next, mixed type means we can see both involved. Okay. Next, we can see some classification of diabetic neuropathy. Total, we have 5 different types of classification of diabetic neuropathy. First one, we can see here, most commonly I saw in clinic, in OPDs, or whenever patient coming with geriatrics with diabetes and everything, I saw this type of distal symmetrical polyneuropathy, DSPN we called. This is the most common neuropathy we can see, polyneuropathy we can see in most cases. Okay, so how the patient will get what the patient will tell means, the patient will tell like glove stocking pattern, numbness, tingling, burning sensation. These are the things the patient going to get. So that's why we call that is glove and stocking pattern, distal symmetric polyneuropathy. Next, we can see that is mononeuropathy. Mononeuropathy means it's like single nerve involvement. The single nerve involvement means it's maybe because of some structural or functional problems. Like for example, in orthopedic, I saw many cases carpal tunnel syndrome. It will comes in mononeuropathy. Next, we can see here whenever the patient getting neuropathy, here we call that is peroneal nerve palsy. Peroneal nerve palsy. Okay, these are the things we can see. And next, head the patient getting means we call that is cervicogenic headache. Okay, so based on that spot, the name will change. That's all. But the symptoms will be like same. But here with symptoms, we can see some associated features also. Okay, so these are the main things. Next, we can see radiculoplexus neuropathy. Radiculoplexus neuropathy means because of some nerve compression, the patient will get radiculoplexus neuropathy. Radiculo means radiating. Okay, plexus means we have some sacral plexus, okay, and brachial plexus. Whenever the plexus getting compression, we call that is radiculoplexus neuropathy. For example, you can see here, if you're getting problem in neck, we can tell cervical radiculopathy or cervical spondylosis, okay, or cervical disc bulge or cervicogenic headache, or whiplash, cervical uh, whiplash, or another one we can say um, cervical myelopathy. So these are the main things we can see in radiculoplexus neuropathy. Next, we can see that is lower back. In lower back, we can see same to same. How we covered in neck and cervical part, same to same. We can see here like lumbar disc herniation, lumbar disc bulge, lumbar spondylosis, or listhesis. Okay, spondylolisthesis or spondylitis. These are the everything we can see in radiculoplexus neuropathy. Next one we can say autonomic neuropathy. Autonomic neuropathy means mostly it's like related to sympathetic and parasympathetic, like heart rate and GIT related things, and bladder and gastro, that secretions and everything, and intestine peristalsis and everything will comes in autonomic neuropathy. Next we can see here that is multiple mononeuropathy. Multiple mononeuropathy means it's like multiple asymmetric nerves. We can see examples like vasculitis. Okay, so now causes of neuropathy. For causes, we have a mnemonic. The mnemonic we call DAN toxic. D means diabetes, A means alcohol, N means nutritional deficiency. So diabetes mellitus, uncontrolled diabetes, more amount of alcohol consumption. If any patient have nutritional deficiency, they are going to get this neuropathy symptoms. Next, we can say trauma, organ failure like kidney and liver, and X-linked hereditary. X-linked hereditary means like some autoimmune problems. Next, I means infection. Next, C means cancer, or if any patient taking chemotherapy. These are the main causes will cause neuropathy. So DAN toxic, diabetes, alcohol, nutritional deficiency, trauma, or organ failure, X-linked hereditary infections, and cancer or chemotherapy. Next, we can see some immunological important causes. For example, if you're seeing metabolic, in metabolic we have to focus on diabetes mellitus. That is the most common cause of neuropathy. Next one, hypothyroidism and chronic kidney disease. Okay, so these are the three things we can see in metabolic. Next one, nutritional. In nutritional causes, we can see vitamin B12 deficiency and B1 deficiency. Because why people will get B1 deficiency? Because of more amount of alcohol consumption. Okay, so next we can see here that is infections like HIV, herpes zoster, and leprosy. We can see, and autoimmune problems like Guillain-Barré syndrome and CIDP and vasculitis. Next, drugs, we can see some drugs also can cause neuropathy like chemotherapy. In chemotherapy, vincristine, cisplatin. So this is the chemotherapy drugs can cause neuropathy. Next one, isoniazid. Next, metronidazole. So these are the main drugs can cause neuropathy. Okay. Next, we can see here some risk factors. The risk factors we have to divide into the risk factors. We have to divide into two different types of risk factors. One is diabetic neuropathy. Another one, painful diabetic neuropathy. So in diabetic neuropathy, we can see because of metabolic syndrome, advanced age, lifestyle, and inflammation. Okay, and some genetics and glycemic control. So these are the things we can see diabetic neuropathy. Painful diabetic neuropathy we can see because of uncontrolled glycemic control, uh, glycemic sugar levels, and female sex, and BMI, body mass index, and neuropathy, and renal dysfunction, and genetics. So these are the things main causes. So here, poor glycemic control, we discussed long duration of diabetes, alcohol abuse, vitamin deficiency, older age, and renal disease and family history, chemotherapy and exposure. Okay, so these are the things main risk factors of neuropathy. Next, we can see here some clinical features. The clinical features we are going to divide into three different types. So based on that type, the patient going to get symptoms. So for example, sensory. The sensory symptoms mostly we can see numbness, tingling. Tingling means paresthesia we call, and burning sensation, electric shock type sensation, loss of vibration sensor. Okay, so here the patient mostly involved three things. Okay, one is feet, legs, and hands. So the patient will get stocking glow distribution. I already discussed this thing in while discussing classification. Okay. Next one, motor symptoms. In motor symptoms, we can see muscle weakness, difficulty in walking, food drop, muscle wasting, and reduced reflexes. So this is motor features. Next, we can see autonomic features. In autonomic features, we can divide into based on systematic ways. Autonomic nerve involvement, we can see first one, cardiovascular system. In cardiovascular system, we can see orthostatic hypotension. Next one, gastrointestinal. The patient will get constipation and gastroparesis. Next one, genitourinary, we can see erectile dysfunction. And in sweat, we can see reduced sweating, and eye pupillary abnormalities we can see in autonomic dysfunction. Okay, autonomic neuropathy. So now whenever patient coming to OPD, first of all we have to take some history taking. In history, based on chief complaint, the chief complaint will guide us what type of based on that location site and the tingling, the patient, when the patient is explaining, that time we can easily find out where they are getting what type of neuropathy they are getting. Then we have to confirm with physical examination. In physical examination, first of all we have to do sensory examination with pin prick sensation. Just we have to prick with pin, then the patient will get, the patient getting sensation or not, we have to ask. Then we have to check temperature, vibration, proprioception, we have to check. Okay, next in motor we have to check muscle strength and if any atrophy is there, and reflexes we have to check mostly whenever patient getting motor exam in motor related problems. Then the reflexes will reduce in ankle, so the ankle reflexes will reduce. So next we can do investigation. What are the tests we have to do in investigation? First of all, labs. In labs, first CBC means the complete blood count. We have to check anemia and infection. Next, HbA1c and blood glucose levels like diabetes and glycemic control. Next we can see vitamin B12 deficiency. Next, thyroid stimulating hormone test we have to check for ruling out hypothyroidism. Kidney function test for checking kidney disease. Liver function test for checking liver. Next we can see some special test, and some special test we have to do. First one, now NNCS means now conduction study. So in this now conduction study, it shows reduced conduction velocity. Whenever the reduced conduction velocity is there, then we have to suspect demyelination. Next we can see reduced amplitude. Reduced amplitude. Whenever the amplitude is reduced, then we have to suspect that patient have axonal damage. Next, another test we have, that is electromyography, EMG. The electromyography is the main test for checking muscle electrical activity, and it will help to detect denervation. Okay. So thing is, whenever patient coming to OPD, that time we have to check first of all how to approach the patient. First, patient with neuropathy symptoms, first we have to take his proper focused history. Then after physical examination. Then after we have to determine the pattern, how that patient getting that tingling neuropathy, that location, site, and what type of characteristic of symptoms the patient getting. We have to know that pattern. Then after blood test we have to do for ruling out. Then after we can check with this nerve conduction studies and electromyography. Then after we have to identify the cause. Then after we have to treat that cause. Then after we have to check that symptoms and follow up. Okay, so these are the things. Now, how to do severity grading? In neuropathy, we have some severity grading based on grades like mild, moderate, and severe. In mild cases, we can see only symptoms. So symptoms only we can see. Next one, moderate. In moderate, we can see sensory loss and reduced reflexes. Next, we can see severe. In severe, we can see weakness, ulcers, and disability. We can check. Next one, we can see management. In management, we can see here that is the management is the main goal for treating underlying cause and to control symptoms and to prevent complications and to improve quality of life. So in general management, first of all, we have to do lifestyle modification. In lifestyle modification, we have to do glycemic control, and we have to stop alcohol consumption and smoking, and balanced nutrition we have to do. Then after exercise and food care and fall prevention we have to do. That is a main non-pharmacological management we have to counsel the patient. Next one we have to check pharmacological. In pharmacological management we can next we can start pharmacological management. The pharmacological management is the main thing. We can start with pregabalin. So in pregabalin, we can start pregabalin, gabapentin, and duloxetine for primary case. Whenever patient getting okay, first of all, whenever patient coming with that neuropathy, we can start with pregabalin. Pregabalin means what? Pregabalin means it's like calcium channel alpha 2 gamma ligand. Okay, this is the class of drug. Alpha 2 ligand, alpha 2 gamma ligand calcium channel. So we can use pregabalin around 75 to 150 milligram. Okay, orally we have to give 2 times per day we can give, and the duration it will work for long term we can use. And the main indication we are using pregabalin for diabetic neuropathy, and we have whenever if patient have renal disease, renal failure, we have to adjust the dosage. Okay, next one you can see gabapentin. Gabapentin also same like pregabalin. It's like alpha 2 gamma ligand. So gabapentin we can use around 300 to 3600 milligram we can use orally. 3 times per day we can use long term. So that the main function is for it will help to reduce neuropathic pain and it will cause sedation. Okay, next drug will be like duloxetine. Duloxetine means it's like a selective norepinephrine reuptake inhibitor, SNRI. We will discuss about this drugs when we are discussing about psychiatry. Okay, psychology series. So in duloxetine, the SNRI we can give 30 to 60 milligram orally, OD, one time per day. Long term we can use, and the main indication for diabetic neuropathy, and we have to avoid severe liver disease. If patient have liver disease, we can't use this duloxetine. Next one, amitriptyline. And amitriptyline means it's tricyclic antidepressants. So 10 to 75 milligram we can use. This is second line drug. After using this thing, if the patient is not getting any recovery, then we have to go with amitriptyline. Second line, orally we have to give at night. We can use for long term for neuropathic pain, and the patient, because of triptylines, the patient will get anticholinergic effects, side effects. Okay, please remember the dumbbell mnemonic. Okay, so dryness, okay, diarrhea, okay, dehydration. Okay, so these are things the patient mostly will get. Next one, last one, we have capsaicin cream. This is the main medication we call capsaicin cream. It's like a topical agent. We have to apply locally for topically 3 to 4 times per day, and the main duration will be like it will vary based on patient that no related problem. The main indication will be like it will help to local pain, and therefore it will cause burning sensation. So we call capsaicin cream. So in alternatives, in alternatives, we have some topical lidocaine we can use, lidocaine patch, or physiotherapy we can do, or psychological support we have to give, and that capsaicin cream also we can use. So now, whenever patient coming with neuropathic features, we have to first line we have to give pregabalin, gabapentin, and duloxetine. But it's preferred because it's like effective and better tolerated and evidence-based medication. In second line, we can go with the amitriptyline, nortriptyline, and tramadol in selective cases. Next, based on if you're seeing in severity-based management, if patient coming with mild cases, the severity based on mild, moderate, and severe. In mild cases, we can treat the cause. Then after we have to do some lifestyle modification, we have to counsel that patient about food care, and we have to start low dose medications if patient getting painful. Next one, moderate. In moderate cases, we have to start with first line neuropathic pain medication and physiotherapy and regular monitoring. In severe cases, we have to start severe neuropathy means we have to start multidisciplinary care, and we have to prevent ulcers. Then after we have to do mobility assistance, and we have to manage the complications. Okay, so now complications. If the main complications with neuropathy, the patient will get diabetic foot ulcers, infections, falls, fractures, amputation, chronic pain, disability, and poor wound healing. So how to do follow-up means we have to monitor the pain score, and we have to check neurological examination. We have to do foot examination always whenever patient checking cleaning, and we have to early morning we have to tell the patient to check properly that foot. HbA1c, and we have to check the drug side effects and functional ability we have to check. Okay, so in exam point of view, I will tell some important points for peripheral neuropathy. The doctor can ask in exam settings or ASCII settings. The most common cause of neuropathy, that is diabetes mellitus. The classic distribution we can see stocking glove type pattern. Earliest loss, whenever patient getting neuropathy, the earliest loss we can see that is vibration sense. So the vibration proprioception sensation will go away in earliest loss. So that's why we have to check vibration. Next, we can see common reflex lost, means ankle reflex will reduce. Next, demyelination means we have to think about reduced conduction velocity. Axonal damage means reducing amplitude. So these are the two main things we have to always we have to remember. Okay, so remember, always nerve damage classic presentation present with burning feet, stocking gloves, sensory loss. For diagnosing, we can do clinical diagnosing and NCS, neuronal conduction sensitivity, and electromyography we have to do, and we have to always focus on glycemic control, food care, and everything. So mostly I covered everything about neuropathy. If you have any doubt, you can ask me in comment section. You can approach me through Telegram. In Telegram, MedSteps Medical Education Telegram channel. In Instagram, we have Dr. Anand Jana. Okay, so if you didn't subscribe my channel, if these videos are helping you, like, share, and subscribe. If you have any doubt, you can comment and you can message me in comment section. So we'll meet in our next video. Till the time, signing off, Dr. Anand Jana.